NEDs today? Excellent. And I'm sure we'll see a few people coming through during the course of the morning. So let me begin by just welcoming everybody. In particular, I welcome Steve to my left, our new Associate NED for Infrastructure and Major Projects, and a little bit round the table, Dr. Matt Lefton, who joined us as our NED with a clinical focus. So you are both very welcome to your first public board meeting, although I think you've observed us previously, so lovely to have you with us. And online, in terms of NEDs today, we've got Karen and Bree and Jackie, who for various reasons aren't able to be in the room with us, but are very much with us in terms of their contributions. So we're going to start the day, as we always do, with a session about some of the work we do or the people that we serve. And in this case, we're talking about people we serve being our staff, particularly important part of CPFT. Without them, we would not be in a position to do the work that we do, which is so important to everyone in Cambridgeshire and Peterborough. And Jo, you are very welcome. It's lovely to have you with us. You're going to talk to us about the staff wellbeing service. And I think a little bit would be quite helpful to everyone to talk about how it's evolved. I know you've got some sets for slide deck for us, but also the impact it's having now and the demand for your services, which I think is something everybody would like to hear about. And so if you want to run through, and then we will probably have some questions. Is that okay?
That's great. Thank you so much for that introduction, and really pleased to be here to be able to have the opportunity to talk about our wonderful service. So I'm just going to share my slides with you. One second. Hoping it all works. Can you see that?
Oh, there, Jo. Yeah. Thanks.
Fabulous. Okay. So yes, thank you for having me today. So I'm Jo St Pierre. I'm the team lead for the Staff Wellbeing Service within CPFT, and I'm here today to talk to you about our fantastic service, what we offer, and the great work that we do. So just to give you a bit of a background, as you say, just to see how things have evolved. So we started as a pilot service in 2017, and we sit within the corporate directorate as part of people services, along with HR, recruitment, workforce development, etc. And I've been with the team since the pilot in 2017 and had the opportunity, was lucky enough to join on secondment and as the team's occupational therapist, and I've been the team lead now since 2021. Also with the team, we have a mixture of full-time, part-time staff, including physiotherapy, occupational therapy, health and wellbeing practitioner, our administrator who holds us all together, and we have a vacancy for an assistant health and wellbeing practitioner as well. So we are internally funded CPFT service, and we provide health and wellbeing support for all CPFT employees, volunteers and bank staff, not to be confused with the staff support hub, which served the whole of Cambridgeshire and Peterborough. That's sadly closed in March. So we are specifically focused on CPFT staff. And all of the work that we do is underpinned by the NHS People Promise to ensure that staff are safe and healthy, and guided by our people strategy and NHS Health and Wellbeing framework. So the work that we do is really to support employees experiencing mental health challenges, musculoskeletal problems, long-term conditions, and also neurodivergent conditions as well. And our real role people to manage those conditions in the workplace and to help them to stay well at work. So we started off, just to go back a little bit, we started off as just musculoskeletal in the first pilot, but we opened up the doors to staff experiencing any type of condition that's affecting them at work. So what we provide a range of support, one-to-one support and also group support. So we have one-to-one physiotherapy and educational sessions. We have occupational therapy support to manage long-term conditions and also to support people back to work when they've been off for a period of sickness. We have a wonderful mindfulness program as well. There's 2 mindfulness teachers, including myself, and we provide mindfulness-based cognitive therapy. We also provide workstation assessments and advise around equipment. And we also make onward referral, swift referral to mental health services like talking therapies and staff mental health service. We have drop-ins as well around the trust, and also have courses such as stress management, back care and fatigue as well, which are very well utilised. So just to really bring this to life, to give you an example of a case that we've worked alongside, somebody who we've supported. And this, unfortunately, is a typical type of referral that we might receive.
Jo, could I just ask you to pause for a second? Because
sure.
We're losing sound at times. So for colleagues who aren't on mute, could you put yourselves on mute? Because I think that's causing some issues with Jo's sound. So Jackie, you've just put yourself on mute. David, if you could put yourself on mute. I'm just looking at the ones I can see. If you can do that, just make sure we can hear Jo loud and clear. All right, Jo, start again. Hopefully we won't have too many more problems, but if everybody who's not on mute could make sure they are muted, that would be fantastic.
I'll move a bit closer as well, so maybe that'll help. Okay, so yeah, just a case example really of a staff member we've supported. So 47-year-old Aggie has been a health visitor for 15 years. She was experiencing back, neck pain and had a couple of days off work due to the problem. And she self-referred to the service and received an initial triage appointment within 6 working days. So we were quite swift in terms of that response for her. So at the assessment that we conducted over Teams, we established that Aggie was a hybrid worker and had been working on just a laptop for long periods of time at the kitchen table at home and was contributing to her neck and back pain. We also identified that there were some work stressors in terms of reduced staffing levels in the team due to vacancies, sickness, absence, which you would see across the board. And she is a carer for her elderly mother and was also had some financial issues, which unfortunately we do see more of now. So she was really juggling lots of responsibilities in and out of work. So the impact of this, as you would expect, is that she was having difficulty sleeping, feeling very tired, becoming irritable, impacting her relationships. And she felt she wasn't performing as well in her role as she used to and had stopped participating in her usual hobbies outside of work. So we often find that someone might refer into our service with some back pain, but when you scratch the surface, there's often a complex mix of personal and work-related factors that might also be contributing to that person's well-being. So what we did, so we first and foremost, we referred her to our team physio for an assessment to assess the nature of the back and neck pain. She was given some guidance around exercises, posture, etc. We had a workstation assessment and she was given advice around safer use of the laptop, what equipment she might need as a hybrid worker and taking regular breaks. And she also signed up to our mindfulness course and attended stress management. We also supported her to discuss flexible working with her manager due to her caring responsibilities. After 3 months, we offered a review and established that her back pain had improved and she was getting more support from the line manager, and she felt that the support support prevented a further period of sick leave. She was also participating in yoga outside of work. So the stresses and strains of life were still there, but she just felt better able to manage this. And it was a really multidisciplinary approach that we took to support her. Okay. So that would be a sort of typical referral that we might see in that case with Aggie there. Unfortunately, our referrals over time have become quite complex, and we do sort of find ourselves engaging in more crisis support at times and sort of fast tracking people to mental health services. Okay, so a bit of data for you. So I'm hoping this is all correct. So we do gather regular data, feedback data, outcome data, and over the past 12 months, we have received 580 individual referrals from staff members. So if we think about substantive workforce, that's around 13% of the workforce in the past 12 months. So 67% of those who completed the feedback form said that the support they received enabled them to keep working at CPFT. And if this was applied to all of those staff we supported, potentially that could have retained 388 staff members in the trust. Also, 47% said it prevented a period of sickness. Again, if applied to all of those people we supported, that would be 272 less periods of sickness. And also 62% improved productivity. That's 359 staff members feeling more productive in their role over the past 12 months. So that is just one-to-one support. We also have had 300 participants to our group programs. And we have 79 health and wellbeing champions across the trust, and provide regular wellbeing advice through our newsletter. So there's lots and lots going on. Okay. We also find its partnership working is really important as part of the work we do, and it really helps to embed health and wellbeing culture within the trust. So we do a lot of joint working with equality, diversity, inclusion, freedom to speak up, learning and development. We work alongside our Head to Toe charity and also the Heart and Soul chaplaincy. So a lot of joint working going on. And also we have worked collaboratively with the integrated care system, delivering mindfulness courses for both CPFT staff and also other services and staff outside of CPFT. So what's next? So we've achieved so much.
Jo, we've lost you again. Could you?
Oh, can you hear me? Can you hear me now? Yeah.
The trick is lean as close as you can to your microphone.
Okay, so what's next? So there's a menopause support is very high on the agenda at the moment. We've just trialled a pilot service funded by Head to Toe to enhance our support for staff members impacted by menopause. If you think 80% of our employees are female, and over 1,000 members of the team, members of staff are within that age bracket. So we're looking to enhance that support. And also there's a lot of work going on at the moment around supporting neurodivergent staff as well, and staff experience and their sort of support within the workplace in terms of managing their conditions in the workplace. So lots going on, and that is our service in a 10-minute nutshell. So really pleased, thank you very much for listening. Really pleased to have had the opportunity to talk about the service.
Jo, thank you. I mean, your pride in and your passion for the service is tremendous, and the number of people who are benefiting from it, I think, is testament to the value of the work you're doing. So let's begin by thanking you and the team for what you're doing. Let me invite questions. We've got one already from Pri, who's one of our NEDs. So Pri, do come in.
Hi, Jo. Lovely to see you. I think we did a service visit. I think I just started and didn't really understand anything about anything, so thank you. I know from feedback from employees, it's an amazing service. And you know, even just hearing it cold without being an HR person, it's a really impressive thing that we offer to our staff. So thank you, first of all, and thank you for the presentation. I've got two questions. The first is, do we see a proportionate take up from the bank and volunteer staff compared to, you know, sort of employees?
Yes, that's a very good question. We do gather that information around if somebody is in a permanent role or bank staff. I don't know the figures off the top of my head, but we do actually have a fair proportion of bank staff coming to our service, which have sort of additional types of challenges due to being bank staff. I think often night shifts and things like that as well, we find. In terms of volunteers, we've just done a little bit more promotion around that because we haven't been sort of getting so many volunteers coming forward in terms of getting support. But, you know, I think that's something we could work on.
Thank you. And my other question is, to be honest, I felt like the list of who you collaborate with internally covers everyone I'd expect to see. Are there any other areas you would like to collaborate with, or do you feel actually, in terms of our infrastructure and how we support you, that all works?
I think we may need to do a little bit more collaboration with our own sort of neurodiverse services, ADHD service, perhaps the diabetes service as well, in terms of general health and well-being. So there are other areas that we would like to reach out to. We'd like to infiltrate everywhere, really, and just be there. But it's sometimes difficult to reach everybody, isn't it?
No, that's lovely. Thank you.
Thanks, Bree.
Thanks, Bree. I'm going to bring in Steve first and then go to Scott. So, Steve.
Yeah, thanks, Eileen. Hi, Joe. A really helpful presentation. Thank you, and clearly having a really big impact. The numbers for 23-24, I think you said 580 referrals, 13%. I just wonder what the figures, if you have them to hand, were in previous years, and is it still a growing number as we go forward? Thank
you for the question. It's definitely a growing number. So we year on year, I don't know the exact numbers, but year on year we're exceeding sort of 600 referrals, and that sort of goes up gradually by about 20 or 30. So we are definitely seeing an increase in those referrals year on year, but I can get the exact data for you.
Thank you.
Thank you very much, Steve. Scott.
Hi, Joe. Scott.
Hi, Scott.
Thanks as always for all that you do, and please extend thanks to the wider team. My question is probably an extension of Pree's. Forgive me if I've missed it, but I'm going to channel my inner Sharon Guilfoyle here. But do the profile of the referrals map onto the demography and the makeup of our staff group as you would expect?
I expect that we do get less referrals from the ethnic minority staff members, I would say, and we have to tackle that. And to make the service more accessible, really, we did have a staff member who would work alongside and attended all of the networks. So there was a direct link between our service and the networks, the LGBTQ plus network as well, and all of the networks. Unfortunately, she left the team. She moved to a different part of the country. So we're hoping to improve that as time goes on, really, in terms of making sure that we have a direct connection with all of the networks. But I'd say we probably don't get as many referrals.
Well, it'll be quite timely because we've got a sort of relaunch of the staff networks coming up beginning of June. So I'm going to look to Chris in part here. I don't recall what the actual structure for the day is, but it might not be unhelpful to find a slot for you to come and talk about the opportunities for colleagues.
Brilliant.
It's a good idea. Thank you.
Let me bring in Karen.
Yeah, good morning, Joanne.
Hi,
like Pree, I think I've visited, and my question is one to amplify the comment you made in terms of your service and the impact on sickness and probably even retention. And I suppose my question is, with more, could you do more that ultimately will benefit the capacity of our staff to stay in work and stay in work well?
Yes, absolutely. I think we're constantly looking for ways to support our staff in the most effective ways. And of course, if we had more resources, we would be able to do that more effectively. I'm very proud of the impact that we do make. But of course, more would always be better. And we do have a vacancy, which we are hoping to fill.
Right.
So did that answer your question, Karen? Sorry, because you cut out a little bit there.
No, absolutely. And I think I, for one, will say we need to fill that vacancy because of the correlation to keeping staff well and in work.
Stephen, did you want to come in?
Thank you, Chair. I mean, just really briefly, I think one of the main benefits of the service, and just aligning that to what you were saying, Karen, is around the preventative, is the proactive type of stuff that the team do and undertake and support. And you know, if you look at the staff survey, we've seen MSK at the lowest level for the last 4 years. We've seen stress related at the lowest level for the last 4 years. So again, I think, you know, there's a clear sort of correlation and impact on what you're doing. I mean, I think there is something about more, but I think it's also about how we do better with what we've got. And there's the level of innovation as well. And it's that proactive type interventions, which I think will make a significant impact, Karen.
Brilliant. It was great to hear you talk about the work that Head to Toe are doing to support you, because Head to Toe have been here to present as well, and it's wonderful to hear about some of the impact of the work that their charitable fundraising does in terms of helping us to support our staff. I'm just interested in your thoughts, Joe, because there's quite a lot of debate in the NHS nationally about how good and effective the support is for staff who work in the wider NHS in terms of mental health support. And I don't know what your thoughts are on the excellent services you provide, but of course we used to have a service county-wide that it's now not running.
Yeah.
What are your thoughts on what needs to be done, really?
I think the closure of the staff support hub was a huge blow. I think CPFT staff are very fortunate to have the support that, you know, within our team, and we've got direct links to the staff mental health services. But that it was quite a blow for all of those other services across the system that don't have the access to support in that way. So it was quite a blow, really. But in terms of mental health support, the staff mental health service have been excellent. I can't say what a godsend they were in terms of you know, being so easy to access, and you know, for staff to be able to access them through us or through their GP so quickly. So I think that's been a great service.
Thank you. We're going to bring in Kathy, and then I think we're going to have to move along.
Just to echo that, I did set up the staff mental health service, but for people who don't know about it, it's a service which is really secondary care level with outpatients and doesn't provide community support, but it's staffed by psychiatrists, psychologists, mental health nurses, and it's meant to be rapid access for staff across Cambridgeshire and Peterborough. So it includes staff in the acute trusts as well as CPFT. It doesn't extend to primary care, and it doesn't extend to social care, but it does serve a very large number of people. It was set up as a pilot, but we've had recurrent funding it's been going 4 years now, set up in the context of the pandemic.
It's COVID funded, of the COVID monies.
Yeah. I suppose the sustainability is an issue, but the feedback is just so positive. I think all the acutes would be very resistant to a closing down. So that's something that's on the agenda, trying to get that sustainable. But it's unfortunate everything's called something very similar.
Yeah.
Because I think people use the terms interchangeably and don't quite know which service they're talking about. But I think what's important for staff mental health service is to have services such as this one you've described, Joanna, and it is a shame that we've lost the hub actually, because they worked very closely together.
Going to invite Scott to have the last word, and then we must have Joe.
Thank you. It's just to follow on from Kathy's point. There is a kind of no small measure of irony in the service being closed down, because if you take the statistics that Joe cited for CPFT and extrapolate those elsewhere for the system of mental health, I mean, the benefits were going to be further there, but the funding was intended to come from the system as a whole, and it was the system as a whole that said we're not going to fund it any longer, hence the reason the service had to stop. But we are looking at something, I know there's 30 seconds, Kathy, on the ask about students. And do there.
Yes, so we have been approached by the University of Cambridge and Anglia Ruskin University to set up something similar to the staff mental health service. So they have had, very sadly, a cluster of suicides in recent years. This initially actually, so they have familiarity both with the staff mental health service, but also we run a service which is commissioned by the clinical school for undergraduate medical students, because they had a cluster of, I think, 4 or 5 suicides over 2 or 3 years. And Anglia Ruskin and the University of Cambridge recognise the growing burden of mental health problems in their students. It's also the case that what they offer is counselling and fairly low-level interventions. Students come for short periods of time. So if you're at the University of Cambridge, you've got 8-week terms. By the time you come in, if you've got pre-existing mental health problems and you're referred into CPFT, you'll probably still be on a waiting list by the time the term is ended. And that means, and Mike, the GP, probably are familiar with this scenario, which means that you've gone through your term without the support that you need to optimize your learning and your experience as a student. So Cambridge got a huge donation from a family where I think there had been either a suicide or the child had become very unwell. And it went to a particular college, but very sensibly, they've decided to do a university and college-wide initiative, because doing it just per college is what really held things up before and made it very difficult to provide equitable care. So we're still working on that business case.
All right, thank you very much. Joe, I think you've heard just how interested we are, how grateful we are for the impact that you and colleagues are having. And so please do, as I said before, take back our thanks. But do keep up the good work. It is just so important. So thank you very much for joining us this morning. Lovely to see you.
Thanks so much. Good to see you. Have a good day.
Thank you.
Bye. Bye.
Bye. All right. In which case, if we can move ourselves along into the main body of the meeting. And we note that we've got apologies today from Brian McCarthy, also from Lauren, who's our FD, but Lydia is with us and covering her portfolio. So Lydia, you are very welcome. Any other apologies I'm not aware of? No? Any declarations of interest which are newly discovered? Mike?
Yes, so I'm a trustee and vice chairman of the Addenbrooke's Charitable Trust. Obviously, we relate to them. I don't think they can present too many problems, but and then the other one is I'm chairman of a small charity called the Cambridge Community Nursing Trust, which gives out grants to people who are having hard times. And again, there may or may not be conflicts, but I thought if I get those on the table now, I don't have to repeat myself.
They're on the table, and I think in respect of both, there's probably more advantage than disadvantage in you holding them. So thank you very much, Mike. I haven't been notified of any other business, so I'm going to say that we have nothing other than the agenda. We move to the minutes of the last meeting. I am going to ask if anybody's got anything from within the body of the minutes that they would like us to correct, or which they believe has a matter within it that will not be covered in other parts of the meeting today. Otherwise, I'm going to ask us to agree that the minutes are a true and accurate representation of our last board meeting in March. Well, we were undoubtedly looking ahead to better weather in May. How foolish was that? Thank you. And then in terms of the action log, as far as I can see, there are no open actions, which is great. And we'll look forward in September to a presentation from our ADHD and autism service, which I know we're keen to have. Super. Then I will move swiftly into my own report, and as ever, take it as read what's contained within it. But I thought it was worth drawing out perhaps a couple of things. And one is to ask you to indulge me with just a personal reference, sort of reflection on what has been almost a year of either being interim chair or chair here at CPFT. And the first reflection I would have is just how busy everybody is. And if I link that to Joe's presentation on staff welfare, staff well-being, everywhere that we go, we see, as I keep saying, but I will continue to say it, amazing examples of the work that is done within CPFT, the great diversity of work that is done within CPFT, and the enormous commitment of our staff. And that's something that when I sit in the car having left a visit, I always reflect on. I do always reflect also, and I suppose I've learned a great deal in the last 11 months, about how history cannot always judge decisions that have been made in the past, be wise ones. And if I think about the way in which mental health services and community-based services, both physical health and mental ill health in Cambridgeshire and Peterborough, have not received the consistent levels of support that they should have done and was merited over many years, but particularly so in the period since the pandemic. And we are living with the consequences of that now in terms of the amount of resource that is available to serve a growing population. So history, I think, that will not currently judge kindly decisions made over the period of the last few years around not prioritising the areas of health that I've just called out. And what we have to do now, absolutely resolutely, is to say that this cannot continue. We cannot oversee the amount of stress and stretch that sits within the system, because against that background of stress and stretch, there are real people who are impacted by having to wait for access to services that they should be able to have certainly more rapid access to. And our staff deserve that we should do that as well. So redoubling our efforts to make sure that the system that we work within is not just acknowledging the demand for services, but is proactively doing something about that, is something that I am very much resolved upon. And the other thing I would draw out positively is that some of you will know that we are in the midst of a recruitment of a new chief executive, not in any way that we're not valuing and welcoming all that Scott is doing for us. But Scott needs to be allowed to return to the golf course at some point.
That's well, I think.
Well, then you are a fair weather golfer, so you're not a golfer at all. But that process is going well. And I'm encouraged by the conversations that I'm having with people who are already saying that they want to be our next CEO, or indeed exploring whether they would wish to be our next CEO. And I think that is really encouraging and a testament to so much of the hard work and hard-won reputation that CPFT has for the services that it provides. And in every conversation, people are referencing the reputation for excellence that we have in a number of areas. We're not skirting the challenges that we have. And they're also drawing out how important they believe our research and innovation agendas are as well. And so I think we must also remember that if others see them as being important, that we too should be regularly reflecting on how we can support that. So I think enough from me, and I am going to ask Scott to pick up the baton, or the golf club, whatever it is that I do.
Thank you. Again, like Eileen, I'll take the paper as read, but just to very quickly counter through a few things. As you'll have seen from the paper, and possibly I've seen reported elsewhere, the outline business case for the Children's Hospital was formally approved. So things are kicking on in terms of moving from outline business case to full business case. I was just going to ask, Kathy, is there anything particularly you want to raise for board colleagues at this point in terms of next
Children's
steps?
Hospital.
Children's
So the next steps are really the full business case, and what we're focusing on are the clinical models, which are very important. So there's integrated models and reactivating some of the work streams that we put on hold while we're trying to get the OBC through. So, for example, the food work stream, the schooling work stream, We're also getting in a bit of external support around IT, which is obviously very important. And the fundraising is going along very nicely, so nothing really to add.
Great. And one of the things we'll be bringing back through the process from a governance point of view is what will the operating model look like moving forward, because obviously we're going to have a physical asset that will have to be owned by somebody, and how are we going to operate, bearing in mind that the model itself, as Kathy's kind of hinted at, is going to be much more holistic, as well as being here being extended in a much more holistic sense. So we'll be bringing that back in due course. We'll pick up the financial position later on, no doubt. Apologies to colleagues at NHS England for a typo in the planning update, where it says that the guidance was issued March 2023. It was a bit more up to date than that, but certainly it was a little bit later than was normally the case. So it should, of course, say 2024. But it's the translation of all of that into an operational plan for CPFT remains a bit of a work in progress. But again, Stephen, is there anything you want to add on that?
Well, currently the plan is being built up from obviously the directorate. It's currently with the exec for formal review before it goes through to BNP and then board. But as you would expect in the plan, it focuses on sort of what, sustainability of services. I think that probably aligns a bit with what Arlene was just saying. It talks about patient flow. Obviously, there's elements in there around the financial challenge that we currently face. Clear focus on development of a new model for MIUs and obviously reducing out-of-area placements. As I say, it will go through the formal governance process over the next month or so.
Thanks, Stephen. Then on the rapid quality review, very quickly, we've responded to our ICB colleagues based on the outcome from the rapid quality review session we had back in April. And we're waiting still for a further response to that to sign off, if you will, the minutes of the meeting, what the actions from that session actually say, how that then translates into next steps, which is in essence looking at an improvement board type product, and how that also aligns with discussions we've been having with our colleagues in NHS England. So I'll be bringing that back by way of regular updates. But that's kind of, as I say, very succinctly a summary of where we are with the RQR process. International Nurses Day, we celebrated. I'm going to ask if there's anything that Jill would want to say.
Yes, myself and colleagues went around the trust on the Friday before International Nurses Day fell on May the 12th, which was a Sunday this year. So we covered it off on Monday and Friday, the Friday preceding and the Monday after. Colleagues across the trust, they were doing their own celebrations, and myself and colleagues within the Nursing Directorate, we visited with biscuits around many areas.
Right, so it goes a distance.
Absolutely, as we possibly could. And it was, to be honest, it was very heartening and great to see staff celebrating, acknowledging the great work of nurses, but also the whole workforce. I think that was very paramount, to be honest. So yeah, it was a good day. Thank you.
Thank you, and again, thanks to our nursing colleagues for all that they do. On the thematic suicide review, I think colleagues are all aware that we've had quite a significant amount of interest in the decision that we took. We're now following through on the commitment that we've given to look at the thematic review in a slightly different sense. But again, Kathy, is there anything you want to add?
No, I think, as you say, we've retained our external chair, Ellen Wilkinson, and what we're looking at is potentially a quality improvement programme around prevention. But we're going to carefully scope that, make sure it's evidence-based and that we have adequate consultation with stakeholders. So we'll keep people posted.
And just again, an adjunct to that, the implementation of the patient safety investigation process is now beginning to gain real traction in the organisation. So we're going to be bringing that back through quality and safety. And as we've kind of got an evidence base to share, but to see that'll be a whole part of that more systematic approach to thematic review that we said we were going to make sure we reinforced. Ireland's picked up on the chief exec, and just to note formally, as I say, the former chief nurse Kenny has moved on secondment to West Hertfordshire. It would also be remiss not to note as well and to acknowledge the deputy chief exec John Webster has also moved on secondment across to our ICB colleagues to look at provider sustainability. So wish John well in that secondment role. I'll stop there.
Thank you very much, Scott. I'm actually going to pass back to you because the board assurance framework is the next item, and I'm going to ask you unless anybody's got any burning questions coming out of your update, that we move on to the board assurance framework, which is obviously where quite a lot of the meat of what we as board should be thinking about is contained.
Great, thank you. So I think it's fair to say that we probably haven't, as an exec team in particular, given the BAF the sort of sense of respect and time that is needed. You know, not because of outright neglect. It's just it's been one of those things that keeps getting pushed down the to-do list. So what we've done, and from a process point of view, is bring it back up to the top of the to-do list, and it's a standing item at the start of our weekly executive team meeting. And we clearly are keen to make sure that we follow through on the sense of expectation and responsibility that the BAF itself should be seen as a real-time document. It should be reflective of what we do, and in particular, we should be focusing very strongly on the areas of mitigation and indeed the timetable for the mitigation, and all of that then should be translated into regular updates on the risk score. So what you have before you is, in essence, a restart of that formal process. It's not by any stretch as I would hope it to be or perfect, but nonetheless, it does reflect, I think, a bit more of a sense of insight to where we are with the key risks that have are deemed to be appropriate to be in the BAF. We're also having a sort of tangential conversation, as we did yesterday, with our wider trust leadership team to make sure that from an operational risk point of view, that we're looking at areas of common instance in terms of each of the individual areas, risk registers, to make sure there isn't anything that should perhaps of itself then be consolidated and brought into the strategic context of the BAF. But as I say, hopefully the paper sets out updates on most of the areas. We did have a couple of slight gaps because of illness in terms of getting things brought right up to date as quickly or as relevantly as we could prior to the paper coming out, but happy to pick up on those issues as well. But as I say, if there are any questions on the updates that are reflected in the detail of the BAF, then happy to field those.
Okay, thank you so much. So I'm looking to colleagues in the room first to see if there are any questions or queries coming out of the BAF. We've always spent quite a lot of time talking about it at the end of last week. But anybody want to pick up on this at all? But could I just ask you, in the absence of questions, but just to talk about, and the BAF does contain it, but it's a little dense, about the impact of the degree of oversight that we are living under at the moment, and how that is actually consuming time and resource.
I think that's the answer. It is. It does feel incredibly pervasive. It's a significant area of distraction for us. It takes up a lot of management time, and fully understand, you know, why some of our colleagues across the system and indeed across the region have a view that it's important that we devote that time, but it does have a significant bearing on what we're doing. And I suppose from a more emotional point of view, it's a bit frustrating as well that we can still find ourselves in that situation when a lot of the evidence base that is giving rise to why people feel the need to be as pervasive as they are has been there. As I said earlier in describing the kind of rapid quality review process and where we've got to with that, we put a great deal of time and effort into responding to the ask of us. We provided the data to support the specific responses to individual questions, and we still don't feel as if we've got a sense of momentum. And one of the areas that in particular frustrates me is part of that process and the conversations I've had with ICD colleagues. I'm not wanting to, you know, speak ill of anybody, but there was a genuine sense of optimism in conversation with the ICD and indeed our regional colleagues about the offer of support, recognising that we can do with a bit of help in certain areas, and that really hasn't materialised yet. And again, I'm trying to be balanced here. It should be a byproduct of how we translate the RQRM, how that sits alongside, or how the NHS oversight issues sit alongside the rapid quality review stuff, how that then translates into the improvement board that we mentioned of earlier. But until we've got all of that, then it feels that, again, come back to the core of your question, everything is focusing on the people sitting around this table by and large.
Yeah, which does not necessarily feel to me to be contributing to driving forward serving
Yeah.
those
Yeah.
people that CPFT exists to provide services to the best. So, yeah, as I said, my reflection is that insufficient time and thought's been given to the services that we provide by our system. Historically, it would be good now, I think, to see some galvanising of everybody accepting that everybody who lives within our geography deserves access to the best possible services, and to actually serve to get some forward momentum as opposed to what seems like at times a spiralling around of oversight without actually achieving forward momentum. So we will return to this. Sorry, Mike, did you want to come in?
No, thank you, Brad, because I'm new to this and hearing about these relationships. And just a reflection, the Integrated Care Board, you would have thought would not only want to support providers, but to support providers working together. And one of the things about CPFT is that it is a key player in terms of helping Addenbrooke's with its flow through.
Yeah.
And I haven't heard anything about that yet. And I would have thought that that will be sort of one area where we've got something to contribute, and with our providers and the PET team and the various things that support discharge from Addenbrooke's to enable them to respond to acute emergencies and all the rest of it. So I guess what I'm saying is that there's something over and above what we are concerned about as a board in terms of our contribution to the system in a service provider way. And I guess I'm telling you what you already know, but it's not here. And I just wanted to give that a little bit of emphasis.
Thank you. And again, I'm going to ask Holly to give her perspective. I'm still relatively new in role, and also someone in Addenbrooke's background. But one of the issues that we raised at the rapid quality review session was we actually weren't members of the planned care board. Absolutely. So that was one of the specific, requests that we made. We should be for exactly that reason. But we also have another dimension to this, which is, as you'll see when we come on to talk about the performance-related issues later in the agenda, we still carry a significant number of patients or service users as inpatients who are medically fit for discharge.
Yeah.
And that isn't necessarily about moving into the NHS. We've got to work with our social care colleagues in particular. So the point you're making is an incredibly valid one, Mike. We are at the centre of a lot of what goes on as an integrated care system. And sometimes that doesn't get respected to the extent that it should, or isn't helped to be facilitated to the extent that it should. But Holly, anything you want to add?
Yeah, I think it's a really interesting point, and I guess I would make the differential between the focus that is placed on physical health versus mental health. So we are a really key player in terms of supporting discharge of people from the acute, so CUH and NWAFT, but with physical health issues. So we provide support in terms of the Joint Emergency Response Team. We provide full service. We obviously have our inpatient rehab unit. We do all of the ICW, so intermediate care work. So we are a really key deliverer in terms of making sure that actually our acute colleagues can try and maintain flow through their work, through their wards. If you look at the sort of oversight and focus that has been put onto mental health flow, it's incredibly lacking. And interestingly, just this week we've received a letter from the NHS England telling us that they are going to have a focus on mental health flow. They've absolutely recognised that the number of inappropriate out-of-area placements has a huge impact on patient experience, patient care, and carers and families. But actually, I've already written to the ICB to sort of say my expectation is that we will have a similar focus on mental health flow as there has been on physical health flow.
Thank you, that's helpful.
Well, let's hope those three. Okay, and I'm grateful to you and colleagues, Scott, for the amount of work you are giving to board assurance. Make sure that it truly is a working and live assurance. That is so important, is our roadmap. So Rick, did you want to come in?
Yeah, thanks, Chair. Yeah, just one observation really on that discussion about the oversight that the ICB are placing upon us. I mean, I guess there's a tension here, isn't there? Because on the one hand, my understanding of the budget is that it's a zero-sum game. So their responsibility is to have a net figure that meets the target, and therefore, if we don't, then somebody else has to fund us to make sure that as overall the ICB meets the target, and therefore they probably have a responsibility to the other trusts that are helping us out to make sure that is done in the right way. So I can kind of see why, I can get the logic of that, but I suppose the observation is, hearing the pain that it causes our trust, is there some sort of review at the end of this oversight? Because ICB is quite new, isn't it? So they may not have done this before. Is there some sort of review that says, well, you need to, with the best will in the world, you need to see the impact of the review that you've done for probably the right reasons, but so that we all, if we ever get to this position again, we maybe can do it with a bit less pain, and than it sounds like it's happening already.
Thanks, Rick. Good question. Scott can talk much more eloquently about the zero-sum game or non-zero-sum game that is the most, but also whether the ICB has any appetite itself to get feedback on its process.
There's quite a long philosophical debate that you could have on the back of your question, Rick, starting with the premise that actually it's about the system. It's not about the ICB, because it's not the ICB's money, it's the system that happens to channel through the ICB. So what I mean by that is how we rank priorities and how the money is applied should be seen as a system-wide obligation, not an ICB obligation. Where it does get a little bit singular is around particularly mental health and the mental health investment standard and how that's being used. So as I said, in a very kind of abstract way, one of the areas we're a little bit concerned about is decisions or views on how the mental health investment standard funding could and should be applied aren't necessarily being taken in the spirit of partnership that I would expect, given we are the experts, we are the lead provider for mental health services across the Cambridgeshire and Peterborough system. And in that very specific point, the rules of the game in terms of mental health investment standard is actually approved alongside the chief executive of the ICB, that we're justifying that we're spending money consistent with what the mental health investment standard is all about. But implicit in that is that we're spending it in the right way and in the right places. And we're not there yet. So that's I would say a very singular example of where we'll get that sense of reflection on how we're working. But to come back to the core of your question, yeah, I think there will be a point where, as an integrated care system, we will need to reflect on how we're working, whether we've got the priorities right. And we're starting to see some of that come through. I was at an ICB board meeting a week past on Friday in Peterborough. And it was encouraging to see some of the items on the agenda being much more reflective of the system, as opposed to dealing with kind of singular issues in predominantly the acute sector. So we're talking about how do we apply health economics more to the population, which in turn then drives the sense of provision. How do we look at the alignment with the local authority board directly using the joint strategic needs analysis and all that sort of stuff? So we're starting to think much more about things from a whole population perspective, as opposed to using very crudely things like payment by results, and that seems to drive what we do, and therefore the money gets channeled into the acute sector to the exclusion of everywhere else, because the bucket runs dry very quickly if the money that's allocated. But there's a whole lot of stuff that's kind of very much beginning to show signs that we're desperate to try and work more effectively as a system, but it still has, as I say, very, very kind of singular areas like the mental health investment standard and our role in all of that I'm concerned about.
Okay, thanks, Scott.
Thank you very much. Okay, could we move on then to the quality and safety area? And Karen, I can invite you just to draw out key highlights from your report.
Okay, thank you, Chair, and good morning, everybody. I'll take the report as read, which refers to the months of March and April, because as you're probably aware, we are having monthly meetings in this area. And I suppose continuing on the theme of demand and the work of our staff, I'd just like to highlight an area that probably doesn't see its name in light, which is the Mental Health Law Performance and Assurance Report quarter. And the quarterly report that we get provides the committee and the board with the information relating to the application of mental health legislation and an assurance that the trust is carrying out its duties under, some significant pieces of legislation, the Mental Health Act, Mental Capacity Act, and the Deprivation of Liberty Safeguarding Act, with due care and diligence. And just to highlight some figures, for quarter two, we had over 140 individuals detained under the Act. And in terms of place and safety, which is the work of the police and British Transport Police, we had over 240 people taken into places of safety, of which 136 specifically came into CPFT, into our 136 suite. So in line with what we've discussed already, significant demand on our services, which is unpredictable. But on a plus, the information within the report is evidence that the duties in respect of the acts have been properly discharged, and that systems are in place to identify matters of compliance, quality and risk. And hence you'll see from the insurance level that we've given it a reasonable assurance. The other point I'd like to highlight is within the quality report is specifically focusing on staff and the progress that we are making around key areas of business. Firstly, CPF hosted the first regional Aspiring Chief Allied Health Practitioners Day in March, with over 100 senior AHPs attending. Positive was received and recognition from the national AHP team. And the second one I would like to highlight is the good work of our infection prevention and control team. They've hosted their first face-to-face link worker study day since the COVID pandemic. And the other thing to note that we've had no COVID outbreaks for that from January to March within our inpatient areas. We are seeing a significant increase in the team's input to support community services, district nurses and minor injuries unit. Is somebody calling me? Is the volume okay?
Yeah, you're just breaking up a bit, Karen, but do carry on. Okay, thank you. And lastly, I'd just like to make a shout out for one of our district nurses as the latest recipient of the Cavil Award, following praise she received from a family for the end of life care she delivered to one of their loved ones. So the committee noted considerable amount of work in progress and the ongoing valuable insight that the improved data brings to the discussion and the understanding of the relevant assurance levels. And I'll stop there and take any questions. Thank you, Karen. Committee. Thank you so much. Any questions or additional comments from colleagues who are also members of the Quality and Safety Committee? It's a very comprehensive report, and the fact that you meet monthly, I hope, is seen as testament to the high level of prioritisation we give to these areas. Rachel, could I ask you to pick up the allied report that goes alongside it?
Certainly, thank you. Obviously, take the report as read. I'd like to alert the board in terms of some areas. One is seclusion. The number of reported incidents have been above the mean as reported. This
want to explain what seclusion practically means.
Okay, so in terms of restricted practice, when somebody within our mental health wards is having a very challenging time, I think it's best to describe it like that, that seclusion is the last part of the pathway. It's the last thing you would do in the process. So starting off in terms of probably in terms of verbal de-escalation, then some physical support, and ultimately resort to seclusion as required. We have looked into those last 7 months of incidents, And I'm pleased to say that staff have appropriately used the least restrictive practice before having to seclude anybody. And I think what I'd like to stress is what we can see from the increase is in line with the discussion earlier in terms of the increased acuity and complexity of the people that are using our services. I'd also like to alert the board to, in terms of the increase in terms of response times for our complaints, this in terms of sign off for our complaints. Again, this has been reviewed as part of the recovery plan. And as a result, the quality assurance process of signing off the complaints has been reviewed and is being streamlined accordingly. So we should be seeing an improvement there. And thirdly, is to alert the board in terms of current pressure ulcer care. So the Trust is delivering care against principles within the National Wound Care Strategy. As a result of this, we are seeing an increase in our category 3 pressure ulcers. This is a change in classification. I think it's worth alerting everybody so that we can, going forward, this will have an impact. Within that, so pressure ulcers currently are often classified as unstageable, but they'll now be classified as a category 4. So we will see an increase. The team are looking at that, and we can do more description upon that within the report. And then lastly, within that, the strategy also recommends the use of Purpose T as a risk assessment tool as opposed to the previous Waterloo tool. The Trust is currently trialling this with a working group before rolling out wider within the Trust.
Just want to explain what that is, what it actually.
This is how you classify the actual pressure ulcer at the time. It's pictorial, but then there's a lot of support from our tissue viability team. It's not my area of expertise, I think.
Horrible things, pressure.
Yes,
we can do to
and
better.
And then two things. Lastly, I would just like to advise the board in terms of violence and aggression that was brought up in the previous subcommittee, and we are undertaking a deep dive review of patient on staff assaults. And board will recall from the last board, we had a discussion in terms of racial abuse of staff, and that is being included in this deep dive. That should be ready for the end of May, early June.
Brilliant.
And then lastly, CQC, we are still awaiting the formal inspection report from CQC following the inspection of our adult mental health wards, which took place early March, as referred to earlier. Thank you.
Thank you so much, Rachel. Any questions or comments from members of the board who are on QNS or indeed anybody? Mike.
Yeah, thanks, Rachel. Can I just expand a little bit on pressure ulcers? Is it all pressure, so community and inpatient?
Yes.
So it includes people. It's just really an observation that, in my experience, pressure ulcers are often a indicator of failure of care, in the sense that they, you should be able to prevent them. And I just wondered if that's something you recognise and or not.
I think in response to that, Mike, I think it's a helpful observation. I think what we need to look at is more detail in terms of where we are seeing them. But there's been over the years certainly lots of work in terms. But where I know from speaking to our Associate Director of Nursing for Older Peoples is particularly pressure ulcers in people's home nearing the end of life. They're particularly the areas that, and there's some choice within that if people aren't wanting to be moved, etc. So yes, it's an issue, an area we need to look at, but it's not always achievable in the family home.
Maybe that's something I could pick up with you at the quality committee in more detail.
That's yes, and Karen, thank you, Karen. Karen's made a very good point in the chat. Thanks a lot. That we also record in terms of people who use our services who come from other areas of care.
Thank you.
But I think it'd be helpful to look at in more detail at subcommittee, Mike.
Yeah, that's great. Thank you very much.
Yes.
Thank you so much. In which case, could we move along? if okay, Pri, to take your report from the People and Culture Committee.
Thank you, Chair. Actually, could I ask before I start, if anybody's not on mute, whether you'd mind going on to mute? Just there's a bit of background noise. Thank you. Yeah, I will
Just before you start, yeah, I think I was going to ask one individual because I can't see everybody free, but I hope everybody is now on mute.
It looks like it. Thank you, Chair. Okay, I will take the report as read. This is based on the last People and Culture Committee, which was held on the 21st of March, although we have had a subsequent meeting last week, which clearly we still haven't formalised the minutes or approved them. I will just pick out a couple of key sort of highlights or concerns. The first is that our vacancy rate does slightly mask the situation for some teams. So overall, we are comfortable with the vacancy rate and that it's, you know, it is where we'd like it to be, but that does hide some challenges within specific teams. And we know that that impacts on staff morale, staff well-being, our ability to retain people, and, you know, eventually presents a risk to patient safety as well. We are hearing that there are some challenges having roles approved and having them filled in a timely way, and perhaps it might be helpful later to just understand better how the cases are put together and how they're approved, and all of that relates to the challenges generally about the double lock process. We do note that the rate of completion of appraisals is still much lower than it needs to be. We are using lots of different methods to try and encourage that rate to go up. And most importantly, we just want there to be positive messaging about the value for employees and also for their line managers of actually going through the process. It's not for us simply a tick box exercise. It's something that really adds value to people's development and our ability to retain staff. The Shaping Our Future Together and the big conversation work is now being rolled out as business as usual, and we've shared a number of things with this committee in the past, including there'll be more learning and development rolled out and more sharing of the behavioural statements that have been developed. The staff survey results were much better than last time, but there is always more that we can do, and I know that Stephen's team are working on that. And then I suppose I will finish with just by highlighting the risk to staff wellbeing and patient safety if critical roles are not filled in a timely manner. And I'll stop there and take any questions. Thank you.
Thank you, Pri. Anybody want to pick up on any of the points that Pri has made? We do make some new points. Rather unfairly, I'm looking at you, Scott, about the process by which we're able to ratify decisions to recruit. I know you're doing everything you can to speed things through, but you want to reflect on that?
Yeah, we are, is the short answer to your question, trying to expedite as quickly as possible. And back to, I suppose, the earlier reference to how we're working through the double lock process with our colleagues from the ICB. I think it'd be fair to say we're getting there in terms of that sense of understanding. But I've made it clear with about the significance of the issues that the pre-drain when it comes to looking at roles, and it's not a one-sided thing. We probably haven't been as smart as we might have in terms of the rules of the double lock and making sure the cases that we put forward are as well made as they could be. Particularly from a quality impact assessment as well as a perception of risk. But what we are doing now is we're working very closely with colleagues, particularly with clinical roles, to make sure that those are filled as quickly as possible, because that's the main area of priority for us in sense of risk. That's not to underplay non-clinical roles, but in terms of direct impact, we work through the clinical roles, and others can probably talk more eloquently than me about the vacancy control process that we go through. But we're trying to make it easier for people in the case as quickly as possible to make the key points of the case, to make it as easy as possible to make the decision to fill. But as I say, we are slightly hidebound by the double lock process and the role backing. But Steve, is there anything else you want to add?
So I think really quickly, and thanks, Scott. I think it's been the right thing to do to put in a process around vacancy management in the context of it's brought us actually in line with other organisations across the system. It's allowed us to give a greater focus and understanding of, you know, that process. So for example, you put a vacancy on track, it's signed off by the manager, it's signed off by the director, the finance lead. It then comes into a directorate vacancy panel process and then the organisational panel process. And it has allowed us to ask some challenging questions actually around some of the roles, responsibilities, some of the grading, that sort of thing. So I think actually having that level of transparency has been helpful. I think you can't take away from the fact, though, by adding in a set of processes, it has actually elongated the you know, from start to finish. So we're now seeing our time to fill metric go from about just over 10 weeks. It's now nearly 12 weeks. And that's the April data. So there's a direct correlation between sort of the process. On the other hand, we're about to digitise the quality impact assessment process. So we are looking at ways to try and make this as lean as possible and use sort of, you know, new ways of approaching this and digital ways of approaching this to try and sort of move it on.
Thanks, Steve. And if we just had one last thought, it's actually also engendering a sense of maturity and evolution in the organisation. We're thinking about the roles that we have. We've got to recognise as a board, we are the custodians of the public purse. So there's a moral obligation, if nothing else, to make sure that we're using public money to best effect, and to the extent that we can use our resources more efficiently. That's a byproduct of that. So I say there's a lot more people. Some, and I can understand why. Some people say, well, it's just about the money. You're blocking our opportunity to provide good and effective care to our patients, which is a fairly reasonable challenge to put. But nonetheless, the rebuttal to that is, well, it should be reflected in the case that you're bringing for the role to make it easy to say, yes, we should be doing that. So I'd say it's causing some not unhelpful sense of reflection on the structure that we have, the resources that we've got, how we're applying them.
Okay, thank you very much. I should add, because I am like a stuck record on this, appraisal rates, to go to Pree's point, appraisal is a positive opportunity for people to just press a little pause button and have some reflection time with their manager. I know that Stephen is undoubtedly going to tell us that they're going to improve since the March meeting. However, it is still not good enough. And I think the NEDs have shown themselves to now be very interested on getting a weekly update on this, particularly around the areas where we have low compliance with actually the completion of appraisals. And I would have to say it's not typically our clinical areas that are low. Say no more than that. But Pree, thank you for your report. Stephen, can I hand over to you?
Thank you very much, Chair. So obviously I'll take the paper as read. I just want to draw out just a few particular points. The first one is around sickness rate. It is now below the target at 404%. Again, I think that's positive, and I think it's testament to some of the organisational work around health and well-being, but also I think it's positive, and it's sort of in line with seasonal trends. The other bit I want to draw out is around appraisal rates. As of April, it's at 71%, so it's gone over the 70% mark, which again I think is positive. But I think it is fair to say last week at People and Culture we had a fair discussion. It was a challenging discussion around, what's that balance between, ensuring that, our staff are given the opportunity to have an appraisal, but also really focusing on some of those key areas where there clearly isn't that opportunity to have an appraisal. And again, aligning it just to the conversation we had at the start around the health and well-being team. There's clearly an element of our appraisal around the health and well-being. So it is about very, very key about making sure staff have that opportunity. And our MI reporting system allows you to go down to a level where you can actually see individual teams and individual members who have had appraisal or who have started to have an appraisal. So we've got that data in front of us and we just need to use that data. And then my final couple of points, it's really around bank and agency. I think there's some really sort of positive news on the bank and agency front. But clearly we use bank and agency as an alternative to staffing when we have vacancies or when we've got sickness or when we've got carer, compassionate leave, etc. to cover. But as you can see, we are sort of seeing fill rates at a 4-year high at 95% or higher, which again is positive. Just remembering the majority of our bank are our permanent staff as well. So again, there's a consistency there from a quality and safety perspective. And then also our break glass shifts. There were over 400 in July 23. Those have now dropped to 161 this month. I think it's fairly early to say that that's been a permanent shift. Because we do see some changes, particularly in some of the medical consultant roles, etc. But again, I think it's just important just to recognise that is positive news, but it's early days. And I'll stop there.
Thank you, Stephen. Any questions or observations from colleagues online or in the room? If people are cogitating, I'll ask a question, Stephen. I've asked before on some of there are patterns to some of our break glass shifts in terms of places we are consistently having to deploy this, and the rather simple person in me does play to should we not just learn from this and actually reorder our staffing model to address the fact that there seems to be a perennial need for the staffing that isn't being met in some areas.
So in the paper, you can see, for example, Ely. There is a significant number of break glass in Ely. I'm slightly looking at Holly here, but actually that will be driven by MIU break glass, and also I would suggest some of the ward in Ely. Clearly, there's a broader conversation which we mentioned earlier on around, one of our key priorities is actually reviewing the model of MIUs actually going forwards. Holly, I don't know if you want to come on in on that one.
Yes, and it slightly touches, I suppose, on what we were talking about earlier in terms of the MIUs predominantly is to try and support the overall system in terms of providing urgent and emergency care and avoiding people to go to the acute CD departments. So I have to say the majority of the break glass in Ely is around the minor injuries units. Actually, Ely has a slightly higher staffing model than the other two units. So quite often they're deploying staff to the other two units to support those and then filling their gap because they have a slightly different skill mix. But as Stephen's alluded to, that there is work underway to look at the future of the minor injury model of care.
Okay. I'm just very keen that we learn. Data tells us things consistently, therefore it commands our attention. Rick, thank you for noting that in the report it does show that the appraisal rate has gone up to above 70%. So we celebrate that momentarily, but then we're anxious to achieve a great deal more. All right. Thank you very much to Pri and Stephen for this. We look forward to learn more about our people and culture in the coming months. In which case, Jane, looking to you to just again take us through the Business and Performance Committee report.
Thank you very much, Chair. So since the last assurance report was brought to the board, we've met on one occasion on the 24th of April, and that was my first occasion chairing it. And so therefore, this is my first report I've written. So go gently with me. I will take most of the report as read, but like my colleagues, just like to highlight a few things. The first is item 6. And that's the finances, and to note, as you've already heard, the year-end financial position, that it was very close to break even, and you'll hear more about that from the finance department from Lydia in a moment. But that was a real effort by everybody in the organisation, and I don't think we should underestimate what an effort it was for people, and thank everybody for that. If I can move on to item 9. We have concerns that there has been a lack of focus on the digital transformation that's going to be required for CPFT. The NHS long-term plan itself underpins the importance of technology in the future NHS, looking to provide step changes for the way that the NHS cares for its citizens. We really mustn't risk falling behind in this area. And we were concerned that we have staff within the organisation lower down who are very keen on the future. But again, harks back to what the chair was saying, that the executive are just so busy that this is an area that has had to drop off their radar because there are only so many hours in the day. But we were raising just a little, maybe dark pink flag, not quite red yet. But it really must be reinvigorated. We must find a way of doing it so that this moves forward. And it's too important not to. And the other item of escalation is around partnership working, and this was covered by items 16 and 17, which covered the provider collaborative, which is the new commissioning mechanism for some of CPFT's work, and the mental health, learning disability and autism accountable business unit. We had updates on both of them, and we saw that there's a lot of good work has been done on both. But yet again, we just felt that there hasn't been that bandwidth amongst the executive to really give the strategic focus and leadership that this new way of working is going to take, due to lack of capacity. This isn't a criticism of anyone on the team. We understand only so many hours in the day, but this is vitally important to how we work in the future in the new model, in partnership with the ICB and the provider collaborative. So those are my two dark pink flags that we would raise, that we would hope to see a way through when hopefully the exec are spending less time being oversought and more time focusing back on the core business. So I'd ask the board to note the contents of the report, but particularly support to encourage that renewed focus on digital transformation, because AI isn't going to wait for anybody.
Thank you, Jane. Really good report. Let me bring in Steve. Did you want to come in then, Mike? Yeah, Steve, Mike, and Scott, and then I'll see if anybody on the screen wants to come in. Steve.
Thank you, Eileen. So I'm looking forward to joining the board, Jane, with you. If I can help with the digital transformation, and see if I can probably more strategic rather than technical sense, and see what I can do to help look at it in relation to the strategy and how it's delivering services. And see if I can do that with the relevant exec colleagues and come back to the meeting with the committee.
That would be absolutely fantastic. Thank you, Steve.
Nice. Similarly, I would support your urging us to, give appropriate attention to digital transformation. I'm sort of interested to read that the appointment of new NEDs is going to be helpful in this regard. So that's great. And just ask a question. I mean, so the way it's done is through this digital transformation board, and so at some point I'll be interested to know how. And the specific question: does it include electronic patient records as part of? Because that's supposed to make life for clinicians easier. Rachel and. But
yes. Well, this came up actually at the medical advisory group yesterday, and as a result of some of the discussions, we're inviting Jonathan Nortonstall to come along and talk. So when I speak to him, he tells me.
I want to explain who Jonathan's. I want to explain who Jonathan's.
So Jonathan is the head of.
He's our associate director for informatics and performance.
excellent. So
he's responsible for the data.
yes,
Technology sits with Richard Matt, who was in earlier on as the for business technology.
In terms of systems, Jonathan's the person who can help us try and alter the system and make it more user friendly.
excellent. And if I may, Chairman, patient access to their records as well is a very important part of that in terms of enabling patients with long-term conditions to manage their conditions better. So there are lots of good reasons for doing it.
Indeed, I mean, Kathy might not agree with me, but System 1 is meant to be one of the easier ones to use of the systems that exist, and easier for patients and service users to access than many of those on the market like. So, but goodness me, this is an area that needs looking at nationally. I would say it's not just us. So did you come in? You look poised. No. Let me bring in Scott, because I would also like a bit of focus on the partnership working as well.
Back to that. On the digital transformation piece, we have a hierarchy within the digital transformation, which is also supported by a clinical design authority, which is led by our clinicians, and you're absolutely right, Mike, it's the forum where changes to how we use our patient record flow, they're initially reviewed by the CDA, and then they come through to the Digital Technology Board to the extent that if there's a consequence of the changes that need to be effected, they're validated, if you will, by the clinicians and then formalised through the likes of Jonathan and his team. And bearing in mind, it wasn't that long ago where we morphed from having two patient records systems, one specifically around mental health, onto a generic solution, which is the system one. So everybody in the organisation uses that. And if I link that to your last point, and when I was saying earlier about that kind of wider partnership engagement, one of the themes that's coming through from the ICS or the ICB on behalf of the ICS is how we use technology in a much more open, transparent way. How do we harness, for example, the NHS app as a portal for sharing an awful lot more with the wider population? But I'll speak for long because digital largely sits within Lauren's brief. We're going to reinvigorate the DTB to the extent that it seems to have lost a little bit of a sense of purpose and engagement with the wider organisation. So we'll be picking that up. It's timely, if for no other reason than our digital strategy. Almost by definition, given the change in pace in technologies, it was a 3-year strategy that, lo and behold, expires in 24-25. So we need to update that anyway. How we use the tools that we have and how we might use other tools was a topic, or is a topic of conversation that we're having in relation to our wider transformation programme. So we reset the Trust-wide Improvement Board yesterday, and one of the key themes that had been a part of the programme some time ago, just again seemed to have lost its way a little, was our approach to future ways of working, which are very much around how do we use the digital tools, how do we apply things like artificial intelligence to help make it easier for people to do their job. So that's also picking up again to the tool of coalesce, if you will, in terms of digital being a high priority for us. But we're bringing the strategy refresh back through here to make sure we're sign off. So input from colleagues would be really helpful on that one. We'll concentrate please hand up as well.
Yeah.
Thank you. The only additional point would be interoperability between providers and Children's Hospital might push that.
So issue.
Yes, because
We have a shift care record at the moment.
I don't really
apply
want
to the
yeah.
in the integration that's needed. That's the big thing yet to be had about how do we support the holistic need of children.
Yeah, no, it's good to put Marcus down. I'm going to bring in Rick because I suspect, but don't know. Rick, I might have thought that you would have some words of wisdom to share on the digital agenda before I bring Scott back in to talk about partnership piece.
Well, I was actually going to comment about the digital strategy, and thank you, Jane, for raising it so clearly, which I obviously share, and all the other comments that have been made on it as well. I mean, I just want to add to the sort of list of things that we have in our strategy that are obviously being held up by this not happening. You've mentioned some of the leading ones. I mean, the irony that one of the reasons that it's not happening at the pace we want is because you're being held up by the ICS. Well, the single care plan and the integrated ICS are absolutely baked into digital strategy. So you're kind of cutting your nose off to spite your face by putting us in this position. But the other one, a few other, I mean, patient access has been raised, digital comms with patients, digital inclusion is another one that hasn't been mentioned. You know, these are all things that we aspire to as a trust. And there was one other one, which I have to say I feel is underrepresented across the whole of the board of directors pack, and that is green NHS. I always never seem to come up, but digital is a key part of that as well. So I was just kind of questioning whether there is a way to put a bit more meat on the bone for both the board and as a governor for Council of Governors as well, so that we can see the nuts and bolts of how digital delivers rather than it's at the strategic level, and that's all quite kind of high level. Whereas the reality is, working in healthcare as I do on a day-to-day basis, digital, I couldn't do my job without total digital support. So I can just imagine what the impact must be like, both the potential of not happening for CPFT as fast as it should, for the benefits of patients, and also, I suppose, financial efficiency is part of it as well. And that's, you know, quite close to our hearts right now too. So it just seems, can we have a bit more granularity on this and include some of those bits that don't always get talked about?
The answer is yes. The issue again about sustainability, we do have a sustainability strategy, but that has tended, I think, for pretty obvious reasons, to be focused around the physical estate and how we use that. But there is deference and reference in that to the use of technology. But you're right, it should also be reflected more explicitly in the update on the digital strategies. We'll make sure that happens. But the efficiency point is, again, very well made, Rick. That's why I say we've got this need and desire to align more effectively how we work. Because we spent, if you look at the investment the organisation's made over the last 5, possibly longer years in technologies. One example, one very stark example, was when the first lockdown was announced. Quite literally, we were the only organisation in the system, if not more further afield, that colleagues were able to come in, pick up their technology and go home and keep working, because we'd invested in the technology to help facilitate flexible working. So we were able to continue and maintain a sense of continuity in how we supported our patients and services as a direct result. So, and we've always tried to be slightly ahead of the curve. But again, going back to the very point that's been made through B&P, we've lost our way a little bit. So we need to regain that ground.
Excellent. Thank you, Rick. Partnership working.
So if we take partnership as a kind of general concept, and then talk about specifically about the 2 areas that I highlighted. Yes, we, again, using the same expression, but we've lost the way a little in terms of the responsibilities that we have, both as the host for one of the partnership models, but also in terms of our general involvement and sense of influence. So we're seeking to address that. As far as the provider collaborative is concerned, other colleagues are involved in the process. I've got to catch up with the managing director of the provider collaborative to make those very points, and we've had discussions specifically about things like the children's eating disorder model. So my intention, and I don't mind saying this in a public forum, is to be a bit more assertive in how I would see us being part of that process, to the extent that we possibly haven't been in the past. So I'll keep you posted on that one. And then in relation to the ABU, myself, Stephen, Kathy met with Elaine Beasley Morgan, and colleagues that were at the development session will have heard firsthand from Elaine about what the ABU is doing. I'm going to chair that ABU board to bring that sense of executive leadership to it, which I think we've lost a little bit of profile and momentum behind. It also plays to the point I was making earlier in relation to the partnership arrangements and relationships with the ICB, because what we want to avoid is any sense that we are the lead provider for mental health, we are the experts in that field, that other people should be making those kind of decisions about how we should be supporting our population with their mental health needs without any deference to us, which at times seems to happen. So the whole idea behind the ABU is that should be the forum for that. It should be inclusive, it should be system wide. It's not specifically about CPFT, obviously. But we need to be, again, a bit more assertive and influential on that, and that's what I'm going to try and do. So the first meeting I will be chairing is a week on Monday.
That is brilliant to hear.
My own information. What's the scope of the accountable business unit?
As it says on the tin, all aspects, mental health, learning disabilities and autism, and it's all providers. So it's everything that is, right, in essence, focused around supporting the population needs of immature people.
Thank you.
To all age.
It's probably for further discussion, but it might be a good idea to have a clinical net on that.
Yeah. I want to. You said, for those of you who weren't in the room, that was a subtle glance across the Dr. Napton there. But yeah, one of the things I want to look at is the membership of that board. Does it reflect that very point principle as to what the ABU is there to do?
Brilliant. Well done. We like to see business being transacted across the table. Stephen, did you want to come in?
Yeah, no, I think it's really, really good to reinvigorate, and I think, you know, the ABU and the model needs to flow throughout CPFT. We just need to be careful. There is no delegated responsibilities down to the ABU yet. We've got close previously. So, for example, you know, all the contractual, financial, etc., sits with the ICB. I think it's fair to say that we're trying to push ourselves. And we want to challenge ourselves on that because we feel we're in a good position to look at this. You know, and there's a lot of governance to go through around that, due diligence, etc., contracts, etc., etc. But again, I think it's really important to reinvigorate that board, to think about what is the purpose of that board. And some of that is around transformation of pathways across the system. If you look at United, for example, where we contract, you know, not just CPFT's contracted to deliver children's services, but Ormiston and Centre 33. It's those type of integrated models of delivery, which I think are really important going forward. And also think about what's our position around prevention. Because obviously you think about, you know, Patricia Hood's report and things like that around prevention. The ABU's got a part to play in all of that as well. So I think it's a really positive step forward.
Excellent. And I think we're getting some updates into the public forward about what we're doing on both. I think would be good to do more regular stuff. All right, Holly, can I ask you to take us through your report?
Yes, indeed. Thank you. I'll take the paper as read, but the areas that I would like to highlight, firstly around right care, right person. So this is a police initiative to ensure that people are dealt with by the most appropriate service if in crisis. So there are 3 phases to that piece of work. We've already implemented as a system phase 1, which was around concern for welfare, and we're currently working with system partners on phase 2, which involves patients being absent without leave and walkouts from medical facilities. So as a system, we're looking at a go live date in early June, but we have agreed that this will be staged, so therefore not a full implementation of phase 2. And in terms of impact for CPFT, we need to amend our policies around absent without leave, and then obviously need to educate our staff on those changes. And just to highlight that we've got a particular challenge around the Fulbourn site in terms of police expectations around reasonable searches. So people who are familiar with the Fulbourn site will know that we've got lovely open green areas, but actually searching that, particularly out of hours, is going to be challenging. So we're just working through with the ICB and police around what can be reasonably expected of our staff. Also like to touch upon triangle of care, so people will know that this has been on the agenda for several months. We are seeing some slow improvements in some areas, but we have gone back to support the directorates to think about their approach, and in particular for adults and specialists, we're going to have an action plan to outline their approach, as that directorate is seeing the least sustainable improvement.
I just wanted to explain for everyone what's meant by the triangle of care.
Indeed, yes. So triangle of care is where we understand for our service users and or patients what support they have available. So do they have any sort of formal carers, or do they have informal caring or support in place? And that's so that we can then involve those individuals with future care planning, because we know that makes a huge difference. We know that involving carers and families in the care of our service users makes a huge difference. So it is important to us, but we are failing to get the traction that we need. So we're having a real focus on that. We've already briefly touched upon sort of patient flow and the importance of patient flow amongst both our physical health and mental health, but really pleased to say that we've got clinical director appointed to support patient flow across the trust. So that's Sasha, who's one of our experienced psychiatrists, and she will be working part-time work around patient flow, reducing length of stay, and in particular trying to reduce the number of inappropriate out-of-area placements. At the latest Unplanned Care Board, the allocation of funding for the continuation of Pathway 1 was confirmed. But I think it's important to note that alongside all other urgent and emergency care funded schemes, they'll be now subject to annual review. So that is something we just need to be mindful of in terms of thinking about the future. We're also currently working with Cambridge Community Services. We have a number of sort of joint ventures with those, in particularly the Healthy Child programme, so looking at the care of children between the ages of 0 to 5. And we're doing a targeted piece of work with them to continue to jointly deliver the service and work more collaboratively together. So that's quite a big piece of work involving the Children's Directorate. In terms of adults and specialists, to highlight, we're still working on opening some additional beds on Malvern 3. So people will recall that we have had some bed closures due to staffing difficulties. We've currently got 6 beds open. We're looking to increase that to 10. We're hoping to do that in June. That is looking slightly more challenging due to our recruitment profile, but the staff and alongside Stephen's team are working really hard to try and meet that deadline. And would really like to highlight for adults the improvement in the majority of waiting lists. So with the exception of ADHD and our autism waiting lists, they've seen a sustained improvement in their waiting lists, which has taken a lot of hard work from both clinical and operational colleagues. So we'd like to note that. And in terms of the ADHD, which we know is a particularly challenged service, we are doing a specific piece of work with the ICB and actually have some quite exciting proposals and thoughts about how we might address the particular challenge with ADHD, which people will know isn't just a sort of Cambridge and Peterborough issue, it's a national issue. In terms of older people and community services, the delivery of type 1 diabetes in the north continues to be challenging, predominantly due to the availability of consultant colleagues from NWAFT. So discussions with NWAFT are ongoing and are being supported by the ICB. But to note that the future model of care for type 1 diabetes is being discussed with system partners. It will be an acute-led model in line with best practice, and as such, we have been served notice for the delivery of the type 1 service in the north, but are part of those conversations to ensure that actually that's a safe transition. And again, in OPAC, we're continuing to see progress in reducing the waiting lists for the memory assessment pathway, which colleagues will remember a policy improvement programme took place. That's seen some really impressive improvements in that pathway. So we're seeing a reduction in the waiting list for that, but we are seeing an increasing demand within our physical health older people services, which is impacting on waiting lists. So we're working with the Directorate to understand how we might take some of the learning from the memory assessment pathway work and apply more broadly. And then finally, for children's, young people and families, we talked through the development of the young person's eating disorder model of care. So we are moving towards a predominantly intensive day case model for young people with eating disorders. Again, that's in line with national best practice. There will be capacity available to support any young person who requires an inpatient stay, but really looking at how we can support them in an intensive day case model and really support working with them in their own homes and their local community. And we will be commencing a pilot of that model in June, so we'll bring updates back through board. We'd like to mention a completion of initial health assessments for looked after children. So doing those within the mandatory time frames continues to be challenging. and the ICB are meeting with all system partners to look at how we can support delivery of that service. We have temporarily had some funding to increase resource, which will help us initially meet that target, but we need to look at the whole service specification to make sure that we can maintain that delivery. And then again, just to mention their waiting list work, so they've done some considerable work on waiting list management that have seen some really great results, but they are seeing an increase in demand, and we're seeing that slowly start to impact on our waiting list. So again, working with them to just understand what was the learning from their initial deep dive into the waiting lists and seeing how we can support continued improvement.
Thank you, Holly. There's a lot in there. I think it's probably just worth clarifying for anybody who's not been involved in this. Around the type 1 diabetes service, we're actually very welcoming of the fact that it is going to be an acute led model, which is a service that we run in this house with our partners in CUH very successfully. So I think we're very confident in our staff and the quality of the services they're providing, but you know, the actual quality of the service overall in North has been an absence of clinical input, and I think we're going to be very clear about that. This is the problem we want to see solved for the people that we are serving.
And I think it's probably fair to say that also diabetes is probably one of the areas that actually the sort of ongoing management of type 1 diabetes has changed enormously over the last sort of 5 to 10 years. And again, the use of technology in managing type 1 diabetes. So at the time that this service was commissioned, a more community-based service was probably appropriate. Now that actually we're looking at far more sort of technical advances in the management of type 1 diabetes, it is right that it has more of an acute focus.
Any questions or thoughts or observations that Holly has been talking through? Another thing was that the issue of autism, ADHD in particular, is a national issue of some significant magnitude. So if there are some exciting proposals coming through, I think there'll be many parts of the country desperate to hear how access can be moved along more quickly. It is a cause of distress to both individuals and their families. Of that, I do know. Anything else at all? Holly, there's a lot in here, so we should thank you and indeed everybody working across the directorates for all that they are doing in delivering high quality services and responding to challenges and issues as they arise. So thank you for that. Lydia, can I invite you, welcome, to take us through the finance report.
I would like to take the report as read. The key points that I would like to draw out of this are the fact that CPFT ended the financial year with a year-end position of about 200,000 deficit, which is very close to break even, which was our plan. And I would say kudos to everybody in the trust for really supporting and pulling together to be able to arrive at this position. This is notwithstanding the main pressures that we had, which included the out-of-area placements, which were overspent as we went through the year. But there were measures that were put in place. And as we went through the financial year, towards the end, we started to see the effects of some of these measures coming in. And I think in that light is the fact that there's been now a trajectory that has been set, and we're working towards that as we go on. The other area that was under pressure, which I would like to state, is the use of agency, which was mainly around the use the medical agency usage, and this was significant. But we've gradually, as we've gone on, seeing this, being able to be a targeted, responding to the targeted process that has been put around to make sure that it's something that is within the manageable amounts. The other aspect I would like to raise is the fact that as at the 31st of March, there was a full valuation of the estates of CPFT, and that actually raised a significant movement on our balance sheet. But that is something that we actually envisaged, and there were technical movements that were made, and that has actually brought affected the way in which our balance sheets came out, which was, I would say, positive, and it's something that we've worked towards. The other aspect is the cash. There was a significant movement in the cash month on month towards the year end, and this was due to the ICB support which we received in March. Just to state that in terms of our capital, we were underspent as at month 12 due to the fact that there was a delay in the completion of a lease. But just to bring all of this in finishing, the main thing is to recognize the fact that a lot has gone into bringing this position, but this position is currently under audit, and this started about 3 weeks ago. And as at this moment, there are no issues that have been raised, significant issues that have been raised by the auditors. I would just like to give an highlight of month 1, which we've just finished, and is to show that we are ahead of forecast based on the plan that we had. And the current focus is on the delivery of efficiency across the trust. And this actually, a lot of energy is going into making sure that we can actually deliver the efficiency that we are programmed for, and to make sure that we are able to do this within a safe environment, not just for our patients, but also to ensure that we are delivering value for money in terms of the funds that have been given into our care as a trust. I'm happy to take any questions.
Thank you, Lydia. Clearly a lot in there. Scott, do you want to come in?
I can make just 2 observations. This is partly speaking as the former CFO. I think it's great that we got to where we got to at the end of the year, but that's not the observation I was going to make. For the benefit of those that haven't been around, the property issues that Lydia is picking up on, we used to do a quinquennial review of the whole estate. This is the 3rd full valuation we've had to do in 3 years, and it's been a pain in the butt because of the way that the indices that are used to set the value for the estate have kind of oscillated. So that, as Lydia's eloquently highlighted, the impact in terms of materiality has been quite significant over that 3-year period, but it does fall below the line, as it were, in terms of how those get reported and then get consolidated at a national level. But there's a lot of work involved in getting that piece of work concluded so that it could be reflected in the accounts, which in turn then brings with it a sense of audit oversight. We'll pick up on audit in a second. But the other observation is again one born out of many years standing frustration. When you look at the age debt and you look at the value for 2 of our nearest and dearest in the system over 90 days, it's always been ridiculous that we can't get our friends in Addenbrooke's and NWAF have to pay their bills because they're not disputing them. It's just they don't clear them. So, as I say, it's a zero-sum game in terms of system-wide cash, but it's more the sense of respect that we should be expecting of our colleagues, that when it comes to making those types of payments, that they should just, we shouldn't have to go begging and ask. But if you look at the over 90-day debt, those 2 elements alone make up a significant portion of the total. That's more than just spending.
We all benefit from occasional little benefit, so thank you for that.
Together, thanks to the team.
Any questions or thoughts? And I just have one that it's, which is it's great to hear the month 1 position. Everybody I know is working really hard to make sure that we are living within a budget. The conversation I don't think we've ever had meaningfully within Cambridgeshire and Peterborough is what is actually the right budget for services that flow into mental health and services to those who receive physical health services in the community. So at one level, we are absolutely relentless about living within budget and delivering good value to the public in terms of this being scarce public money. But at some point, we do need to be able to have a conversation about historical decisions I've referred to at the outset, whether actually that's good enough. And I think we must be more assertive, to use Scott's word, about how we're having that conversation meaningfully and impactfully. If we could then move on, and I'm going to look to Scott in Brian's absence to give us the report from the audit committee.
So in the absence of both Brian and Lauren, first confession, I wasn't actually at the audit committee, so I'm playing from both briefing and from what the paper says, but as always, I'll take the paper as read. Just a couple of quick observations, and one of which Lydia's already picked up on, and that's to do with our external audit. So as you'll see from the paper, the interim work has been completed, and we're now going through the kind of external checking of the numbers in the draft accounts. I was in Kingfisher last week, and it was really good to see colleagues from Azerta and colleagues from the finance team working very closely, very collaboratively, in a very mutually respectful way, because these periods are very intense. They can be a little bit distressing in terms of how the questions are asked and answered by our auditors, but the assurance process that comes from the external audit process itself seems to be working very well. It's good to hear from Lydia that touch wood, thus far there are no fundamental issues that have been raised by assets. The second issue again is one that I'm picking up with Lauren particularly. So again, I can't help but think through when I was a CFO, the head of internal audit opinion is something that is quite significant for the benefit of those that are not familiar with the difference between internal and external audit. Our internal auditors look very much at our system of controls across the organisation, not just to the extent that they exist, but that we're also we're applying those controls and living within those controls. So to have a head of internal audit report, which is largely predicated on the field work that internal audit do each year, being veering towards one that says not quite sure that those controls are being applied as they should be, obviously is a bit of a flag for us. So we'll be picking up across the organisation, and not just in those areas where the internal audit reviewer has highlighted where there are some concerns, but more generally, and of course, for the benefit of non-exec board colleagues, we have this regular discussion about where we are with our update and currency of our policies. So it plays into that in terms of not just the policies themselves, but our standard operating procedures and so on and so forth. So as I say, we'll be picking that up, Lauren and I and the wider exec team, over the course of the next few weeks. And then lastly, just on the section 5, which talks about the items to be followed up, we should recall or remind ourselves that the audit committee is an audit assurance committee. So it looks very closely at the risk registers on behalf of the wider board. So again, as we discussed earlier, in relation to the BAF and the operational risk registers, the audit committee will be giving, through Brian's good offices, very close attention to where we are with the risk registers, and making sure, as we've already stressed, that they do reflect the currency of the situation, that they are being updated, and indeed the sources of mitigation and the timeframes associated with mitigation are being followed through. I'll stop there.
Thank you so much. Any questions for Scott at all? Mike?
So one of the things that jumped out for me, but thank you very much, was the medicines management internal audit at minimal assurance, good control framework, but consistency with compliance. So I just wonder if that, and it's the second time medicines have come up, because in terms of supply of medicines was another issue earlier on in the paper. So I guess the point is this something that the quality committee should be cited on as well?
I shall definitely pass to Kathy and.
Yes, I think this is quite recent. I know Lauren from the audit has had a discussion with her chief pharmacist who has it under control. I have yet to have my meeting with the chief pharmacist, so okay, I'll report back. But yes, absolutely. The quality meeting, yeah, no, absolutely.
That's what you're saying.
Burning Karen, but yes.
No, absolutely.
No, it is absolutely critical to get this right. Karen's board should be receiving the reports of the internal auditors, and we need to be constantly monitoring this.
Yep.
in terms of the unavailability of medicines, I think it is worth noting, it's a national issue. It can be cyclical, it can be particular to types of drugs, which then miraculously arrive, and then another shortage appears for another type of drug. And our pharmacy colleagues here do very well in sorting drugs, but also supporting other providers with drugs. So Kathy, I don't know if you want to say anything.
There is a system-wide approach to the drug shortages, and the main ones that that's the ones relating to diabetes and also ADHD. The others less of an issue, and we have managed so far. And Claire, our chief pharmacist, meets with the other pharmacists within the ICS. They look at supplies, they anticipate what needs to happen. So there, I think that part has been managed quite well.
All right, thank you very much for that. Could we move on, if that's okay, to Jackie, taking from you your update on the Charitable Funds Committee.
Thank you, Eileen. Just to, before I start, this report refers to Professor Ed Borman, who this was the last meeting he chaired, and he's now gone on to sabbatical, and I look forward to welcoming Mike onto the committee with his wealth of experience from his role he plays at ACT. And it was great to hear, wasn't it, from the earlier presentation, the mention of head to toe in relation to the support for the menopause programme that Joanne and her team are leading on. The financials for the end of the year in the report speak for themselves. We achieved a 260,000 income, which represents a growth of 52%. The Trust is relatively new, and it's growing, and it's moving forward, and it has a fantastic charity manager in the guise of Hannah and her team, and they have also set out for the board the strategy for the next few years, and I'm happy to share with the board, because it's not included in the report, the strategy that was signed off at a previous board meeting. The target for this year is another 351k, which represents a further 35% growth. And the focus for this year is very much on 2 or 3 themes. One of those themes is around improving end-of-life care. Another one is very much around our green wards, and I visited one of our maple wards a couple of weeks ago and saw for myself some of the great work that's going on there in turning some of the internal spaces into great green spaces for patients. This charity continues to support both patients and our very valued staff, and will continue to do so. And finally, just a shout out for any of you that are keen bike riders. We are back doing our annual sponsored bike ride on the 11th of August. So if you can pedal for 50k or 100k and you would like to join that ride, then I can forward on some charity details on that, or just line the route and give a shout out for all those that are cycling and sponsoring. Thank you.
Thank you, Jackie. And just for me to know, I should have said it at the outset, Professor Ed Bulmore, who is one of our non-executive directors, is still very much with us. He's on sabbatical until September. Ed is an active research professor at the university, and he's away from us to focus on that, but only until September, when he will return, and we will look forward to it. And Jackie, thank you for the report. We should note, as you said, and celebrate the increase in funding Hannah and the team have been able to generate. But we've got to be ambitious to do more. And the reference to the greening agenda, I think, is really important. If Ed were here, he would be passionate about the evidence that using the natural environment, opportunities in that natural environment to therapeutically support people is very considerable. So using head to toe to enable us to do more in that area, I think would be great. But any questions at all for Jackie or observations that people would like to make? So there you go, the invitation to anybody who can ride a bike. I can't, I failed at stabilizer level, so you're not going to get me, but I'm happy to sponsor. Yeah, it's fantastic. If anybody wants to do a bike ride, even better. Okay, can I thank you for that? At this stage, I would usually ask if we've had any excitement of using the trust seal. This month, I can say we have not had the use of the seal, so there's no cause to be excited about its use. So we will do that. Which brings us in a timely fashion to just the opportunity for any questions, either those who've joined us online who are with us a little less frequently, or indeed any members of the board who feel that they've got issues that we've not been able to cover. So let me go to Jonathan first. Jonathan, you're very welcome.
Yes, thanks very much, Chair. So people will know I'm Jonathan Wells. I'm from Rethink Carer Support. I just had one question. I'm not quite sure who it's directed to, but this is around the pressures on community mental health services, which I think have been touched on this morning and everyone is aware of. As I understand it, the Stop the Line process has been used at least once recently by staff to highlight the extraordinary pressures that they're working under and their feelings that they can't provide always a safe service. So I just wanted to ask, is that correct, the way what I've just said? And secondly, I guess perhaps from the executive team, possibly Holly, have the trust been able to come up with anything that helps make locality teams in particular a little bit more safe than they sometimes are?
Thank you, Jonathan. I will pass to Holly or indeed anybody else who wants to speak to this. I think you are right in the way you've described things. There's been a theme running through this meeting of the quantum of resources that exist to do the job that we are here to do. And I make no apology to anybody who might view this in any other organisation who's looking at it saying, don't whinge. We are not whinging. We're simply saying we're doing the best with what we've got, but we do recognise that sometimes it's too hard for our staff and it's not good enough for those we serve. And I will never make an apology for calling out what is true. In terms of our community teams, they certainly are dealing with people who are, there are more people who are using their services, and some of those people are more poorly than those teams have ever had to deal with before. So we're asking an awful lot of our staff, and they are rightly saying to us that sometimes it feels like it is too much. But Holly, do come in.
Yeah, thank you, Chair. Thank you, Jonathan. So you are right in terms of our community adult locality teams have raised concerns around the increase in activity that they are seeing, but also the increase in acuity. And alongside that, having some staff shortaging in terms of vacancies. So we've had several meetings with those teams to look at how we can support. I think the first action that we took was to make sure that actually all their vacancies have been released and we weren't holding those up through any internal processes. So those posts are now out to advert, and we obviously hope that they will be successfully recruited too. We also looked at actually how we could perhaps look at the resources, because one of the challenges with the adult locality teams are it isn't a consistent level of demand. There are peaks and troughs, and across the county those peaks and troughs are different, but that does provide us with an opportunity because it looks at how we can share staffing, and actually if one particular team is seeing an increase in acuity and demand, looking at the demand on the other teams to see whether we can share resource across the teams and provide that support. We have also looked at how we're sort of prioritising and triaging patients. So as Eileen has mentioned, some of these patients are some of our sickest patients in the community, and we need to make sure that when we've got limited resource, that we're focusing that on where the need is most. So we are supporting the team with being able to prioritise and triage patients so that we know that those in most need are getting our attention in the time frame that we would want them to. And then Rachel and I have just started to have discussions around, is there anything further we can do with the primary care health, mental health service to support? Is there something we could do differently, either with resource or in terms of which patients are being referred to share some of that load?
Okay, Jonathan, it's quite a fulsome answer, but I think, oh, so I'll bring in Kathy before I go back to you, Jonathan. Kathy.
Yeah, I mean, I agree with everything Holly has said, and we're doing what we can to support the situation, but it does go back to Eileen's comment about resource. This is a very circular situation. So, for example, if you can't discharge patients from the acute wards because there's no rehab pathway, because social care can't pick up the patients who are medically fit for discharge, it means you have an accumulation of patients in the community teams who are getting more ill, patients who would normally be admitted to hospital. So the community teams are carrying very high acuity. They then need to keep their thresholds very strictly defined, which means you've got more ill people behind that in that primary care section, and the opportunities for prevention are just not there as a result. So it just goes that there's an impact all the way back. And we had a very interesting talk from a consultant from Avon and Wiltshire recently, which some of the board attended. It was at the medical advisory group, and talking about patient flow and what they've done. But he made the point at the start, which is absolutely true. If you look at most mental health and community trusts, they either are very well resourced for beds or they're very well resourced for community services. We seem not to be very well resourced for either. So it is a significant resource issue. So we're making the most of our resource, and we're putting in place mechanisms to try and optimize and support staff, but it is a challenge.
Yeah, well, I'll just say very quickly, thank you very much for those very clear and thorough answers. I wasn't expecting any magic around these particular problems, but obviously the families I hear from have plenty of evidence of what it's actually like at the moment. Just one final thought: if you're looking to try and find these partial solutions, I would be happy to be involved, providing a sort of extra perspective, if that was any help. Because sometimes that, you can see things a bit freshly from outside sometimes. So that's just a thought. Thanks very much.
Great answer, thanks. You okay to move on? Or did you want to come
Well, if I may, just 2 seconds, slightly longer than 2 seconds. The other side of your question, Jonathan, is about the Freedom to Speak Up process itself. So we had our trust leadership team meeting yesterday, and a very good update. A bit of tongue in cheek, this particular topic appeared twice on the agenda, which was just by way of the way the agenda has been put together, but it was a single item. And we are looking at how we can improve and encourage colleagues still to use the process, but also, again, to use that term, we're looking at things from a much more thematic point of view. But Rachel's feeling a piece of work to do with this.
Yeah, so in terms of the stop line, Jonathan, you'll be aware that that's been a process in place for many years with the trust. And when it was first developed, it was quite rightly so developed for staff to raise concerns about immediate patient safety issues. I think as we've moved on through the years, where there's certainly demand outstrips capacity, it gets used in different ways, which is absolutely fine. So it's quite appropriate that we do have a look at that and make sure that it's getting the level of oversight, particularly from executives, that staff are expecting of it, I would say. Alongside that, obviously, we need to think about the other processes that we have in terms of risks being raised through the usual processes, through team structures, operational risk register, the PREs and the like. And as Scott's also referred to, freedom to speak up, where staff individually may have a concern. It tends to be that Stop the Line tends to be a team raising their concerns about issues, and freedom to speak up about individuals raising their concerns for themselves about how they're being treated. So there's subtle differences, but they're all really important processes that we support and really value.
Yes, I get the differences. Is it possible for it to be in the public domain about the number of Stop the Lines that are per quarter that are actually happening? That's my final question.
I would certainly, certainly don't see why not, and I suspect it is if we look at the data that's actually provided. I'm more than happy to highlight that specifically at each board, Jonathan, if that's helpful.
Yeah, that's a good indicator of staff's own views of what's going on. Thanks very much.
Rashid, thank you. Really good question. Do we have any more questions? Mike?
Just an observation. Hello, Jonathan. I don't know if you remember me, but our paths crossed when I was in PCT, PCGs and all of that. And it's really just to highlight the importance of listening to patients and carers' views through the so-called third sector. And we've got a quite vibrant third sector round here. Certainly there was. And so just as highlight the value of that to us. And that's probably Jonathan's intervention.
Yeah, a helpful
really
reminder
helpful.
of that.
Yeah.
Excellent. Thank
Thank you.
Can I say an enormous thank you to everybody who has attended today. It's lovely to see you all. Katrina, thank you for helping to make the meeting happen today. It's not your usual day job, but thank you so much for that. We're going to draw to a close. But Katrina, could you, as you stop the recording and as colleagues who aren't board members leave, could you leave the meeting running so that the board members can just have a little moment or two for reflection, if that's okay?
Yes, of course.
But thank you to those who joined us today, and say really lovely to see you all.
Thanks, everyone.
Thank you.
Thank you.